Hello, it's my great pleasure to welcome you to our next webinar in the series of patient partner involvement in clinical research. The topic of this webinar is patient partner as a study co-principal investigator. My name is Karolina Werynska and I'm a scientific program manager in Rising Plant Foundation for clinical cancer research. And it will be my pleasure to moderate today's discussion. Our webinar is a joint collaboration between Rising Tide and LUNGevity. And today with us is a representative of LUNGevity. Upal, would you like to say a few words?
Absolutely. Thank you, Dr. Werynska, for your partnership. My name is Dr. Upal Basu Roy, and I'm the Executive Director of Research at LUNGevity Foundation. We are so delighted to continue this series of webinars that we've created to assist researchers and to assist patients in meaningfully collaborating to create research projects that answer questions that are aligned with the reality of our patient community. And I'm very grateful to our panelists today for sharing their time and expertise in telling us how patients and researchers can work together to co-create a research question. So back to you, Dr. Werynska.
Thank you very much. Yes, with that, I want to share a few words about the concept of this webinar. Yes, as we've heard, the aim is to really foster and promote collaborations between patient, caregiver, research advocate, and researchers. And we hope that this will educate both patients and researchers on how to co-create around different aspects of clinical trial, provide examples of engagement tools and strategies that have worked well in the past, and discuss metrics of success for these partnerships. The audience that we hope to attract today is both clinical researchers and patient partners interested in co-creation of a research project. And specific objectives of today is promoting patient caregiver involvement in clinical research, sharing a real-world example of patient caregiver and clinician partnership and co-creation of a clinical trial, and finally highlighting the success stories of a patient partner being the co-PI of a clinical trial. And without further ado, it is my absolute pleasure to introduce our panelists today, Professor Dr. Elizabeth Kappos, who's a surgeon with specialty in breast cancer from University Hospital Basel, Switzerland, who's the principal investigator of the Lymph Trial, and Professor Maria Katapodi, who's a professor of nursing and a research group leader in clinical epidemiology in University of Basel, Switzerland, who's here today as her in her role of a patient partner and co-PI of the Lymph Trial. Thank you both very much for joining us today.
Thank you for having us. Of course.
And perhaps you could tell us briefly about the concept behind your trial and walk us through its background.
Yeah, thank you so much. I think it's such an important webinar. We are doing such an important exchange, and I really hope we can help many others to be as lucky as I was to find Maria to help me and help us to bring this forward. So the Lymph Trial, as you said, I'm specialized in reconstructive breast cancer surgery. But as a part of that, I've been concentrating on the treatment or the surgical treatment of complications that can develop after breast cancer. And one of them is chronic breast cancer related lymphedema. Depending on the treatment for the breast cancer that a patient had, it occurs in between 5 and even more than 40% of patients. Different treatments cause different probabilities to develop this complication. And patients who develop it, they really suffer. They have a very high burden. It can cause pain. It causes this chronic swelling, heaviness, also really psychological impact, and it prevents them from working and just acting like they used to. So really hinders them in their daily activities. And if you look worldwide, the current treatment standard for this really, say, horrible complication that can occur after breast cancer treatment is what we call a conservative treatment. So no surgery, but a combination of complex physical decongestive therapy, which is manual lymphatic drainage, usually performed by a physiotherapist, and this in combination with compressive garments. This can help to stabilize or somewhat improve the symptoms of the lymphedema, but it cannot tackle or cure the lymphedema on its cause. And that's why we developed the Lymph Trial, because there are surgical treatment options that we can offer the patients, but those are unfortunately still in many countries not covered by the insurance companies, because the clinical evidence that they are really superior to the conservative treatment only, they are missing. This evidence is still missing. And these microsurgical treatment options, they are very minimally invasive, with very small cuts that we do in the course of the wrist or the arm. We can reconstruct the lymphatic vessels. We can bring them, we can make their flow go into small veins in the surrounding area, or we can transplant lymph nodes from another area where they are there in abundance to help recreate a new network of lymphatic vessels. And this can really help the patients and recreate this lymphatic system that has been damaged by the cancer treatment.
And I want to add here one thing, about the burden of lymphedema. It's all these like side effects and all this. It kind of like it is a constant reminder to the patient that they have been through a major surgery, and it's a constant barrier that does not allow them to go back to what they would like, which is their normal life, and do the activities they were doing before. So maybe the pain is not, maybe like even moderate or small lymphedema, maybe it's not an obvious pain, or it's not obvious obstruction in movement, but the fact that it is there and it kind of constantly gives a signal of pain of 2 out of 10. 2 out of 10 is not considered like major pain, but it is a constant reminder that, I have to live with this now for the rest of my life. So I think that's an important, from the patient perspective, to be told, even for patients with minimal burden, but it can mean a lot for them.
Yeah, see, that's so important, and that's why I think this is why we decided very early on. So I think the specific thing is that the research question itself, to concentrate on this on the lymphedema and the potential of the surgical treatment, was really also decided on by patients. This was even before we really developed the protocol and all that. It was it's called the Oncoplastic Breast Consortium. It was founded by Walter Weber, the head of breast surgery at the University Hospital in Basel, and this is like an institution or a collaboration that has been bringing patients and surgeons, not just surgeons, but specialists from many different areas together, and patient advocates have traditionally a very strong voice there. And that's where this research question was really brought forward. That's when we decided, okay, we will really try to tackle this. And then the question was, okay, but what do we look at? And I think that's what I'm getting at is what Maria just said. We decided the patient-reported outcomes, really how the patients feel every day before and after the treatment that they get. That's what should be, this in the center or at the core of this trial. And this has made it very special, and probably has been also one of the reasons why it's gained a lot of also media attention, because it's really something new in surgery that finally we as surgeons accept. It's not just us judging whether the surgery was a success, but it's the patient. And if you cannot prove that the quality of life of the patient is improved after the intervention we are doing, we probably shouldn't be doing it. And so that's what we developed together. In the end, we have to include around 300 patients. We're collaborating with now over 30 hospitals, really worldwide. And we randomize the patients in those 2 different groups, the microsurgical treatment, or they continue the conservative treatment that they have already been doing before. And then we, of course, also look at objective measurements, like the arm volume, how that develops. But as Maria pointed out, it doesn't necessarily correlate how big the arm is with how much it impacts your quality of life. So the patient-reported outcomes, the questionnaires, are the primary endpoint of this trial. And the primary endpoint is being measured 15 months after randomization, but we follow the patients in the end for 10 years to have a long-term follow-up.
Thank you. And with that, I think we're moving on to the patient partner involvement in the trial. Maria, would you like to say a few words?
Yes, absolutely. First of all, I would like to reiterate, my sincere thanks for the opportunity to really present this story to others and present the case of the Lymph Trial, which I think is a case of a very successful collaboration that brings forward a new paradigm of how we can move forward in research in medicine, surgery. So, as Elizabeth said, the most important outcome is for what does it really mean for patients, right? And the impact that it has on their life. The ability not to use the arm, or the ability not to be able to be dressed on your own or do different activities you were doing before, it really depends. It's very different from person to person. And I think I have shared, an example of a friend who was trained for years to become like a dentist, and even with small swelling lymphedema, it was not being able to have the same dexterity has a far worse impact for her compared to someone else who does maybe a different kind of work with the same amount of objective data. So the arm could be the same, the swelling could be the same, but the impact on daily life, going back to work, assuming your prior work, can have a significant difference. So what is relevant for the patient? So that is definitely a part where the patient voice needs to be included. It needs to be there. Maybe it is a new outcome. I'm talking now in general, not only about the Lymph Trial. I'm talking in general. Maybe it's a new outcome. Maybe it could mean adding another small part in the research. Maybe, in order to answer that, to identify that, maybe you need to do some pilot work, some interviews prior. But that, it allows, it needs like open-mindedness for both from the researcher point of view, and also, the proactive patient that he says, this is really what it means for me and for others. So I think this is really, and also the significance, the impact of the question for the patients. I think for the Lymph Trial is, I don't think we need to reiterate that for the Lymph Trial. Now, in terms of like study design and the funding application, the trial is a pragmatic trial, right? I mean, it allows that if, someone has been allocated in, randomized in one group, let's say the conservative therapy, but they keep on getting worse, they can be reallocated to another arm. I mean, Elizabeth, help me here if I don't remember all the designs here. I'm wearing my hat as a patient and not as a researcher. So that's, that's what my recollection is.
It's very true what you're saying, and the pragmatic trial was also very new to the community. So in the beginning, I guess before it really jump started, I had very tough discussions with other, famous professors at scientific meetings when we presented this, because it used to be that you had to, basically control everything to make sure there's no bias impacting what you're trying to show. And the idea of doing a pragmatic trial where you're doing what you're doing and you're just documenting everything, which then gives you the opportunity to kind of really say, okay, if these are our results, this depicts exactly what is being done in clinical practice, so we can directly translate it. This was really new, but it's now more and more coming. So yeah.
Exactly. So I think that's very important, because it really helps also bridge the gap from the research to the implementation. I think this is already 5 steps forward. I think by doing a pragmatic trial, you really leap forward 5 years. You know, they say it's about 10 years between the discovery and the implementation in clinical practice. And I think a pragmatic trial cuts down that time in half. So it really helps that real implementation. Reducing burden for the patients. That's another very important aspect. So visit as far as possible in routine care. When you do a clinical trial and you want to involve patients and you want to maintain your patients, especially in the long-term run, not having extra burden, what we call the subject burden in research, but you really, understanding the reality that someone is battling their cancer diagnosis, they are battling a lot of their additional issues. The visit in the hospital, it's only a small part of the whole rehabilitation process. It is 1 hour, but that rehabilitation happens 24/7. And actually, this is more of that happens outside the hospital in the patient's home. And not adding burden to that because of the trial, So adjusting the schedule, the measurements, the data collection points to the routine, what the patient would do anyways, and adding. But that means flexibility in terms of, when are you measuring this, how. So you need to have, you really need to be able to think very creative, right? But also have the resources, to have the personnel available there when the patient visits, or maybe in some other cases, maybe not here, but in other cases, maybe arrange for measurements to happen at patients' homes. But understanding that reducing the burden and making it feasible, it will make the patient more engaged. And it will give, it makes it more real for them and more, it gives definitely more, it contributes to the pragmatic aspect of the pragmatic trial. Let's put it like that. The patient support, the PPI, the patient representative support. I don't think it's okay that we ask patients to, pay out of their pocket or, some sort of compensation. And it's also, how can I say, it shows some appreciation for the time, that, and the energy and the input that they provide. I don't know how Elizabeth, did I?
I think you covered all the bases. I can only add that's what Maria is saying, to make it really easy for the patients and to really have the burden on them as low as possible is something that we continue to work on, and we're still working on it. I think this never stops. So, for example, in the beginning, we agreed also, with Maria that it would be very important to have all the measurements, for example, at the main study site, but we discovered that in certain areas, like for example, one of our sites is in Vancouver, where the patients sometimes have to travel almost a whole day to get to the center. This is simply not feasible and would really hinder participation of patients in the trial. And so, we worked on an option to have these remote visits added, and this just recently got through the ethical committee. So I think, you can never stop also there trying to improve also during the process of a trial.
And I want to add one more thing here about like the study design. I think, researchers, we understand the need to control everything, have the clear control, allocate a random allocation where you would get the treatment or the placebo, the nothing. And this is part of the training we, like all the research community, we have been receiving. On the other end, from the patient point of view, that understanding is not there, right? And it's not really, it's not always acceptable that oh, I will be in the study, but I will get nothing. The control group, right? So here I'm talking. So I then understanding that our need to control for everything for in a trial and having that control group that gets usual care or that gets the nothing, you know, that is not necessarily common knowledge among the patient population. And so this is like, if the patient advocates, you know, they say, well, you know, the control group needs to get something, right? Here we have to be kind of creative and say, okay, what is that something that we can provide that will not compromise the integrity of the study, but the control group, they will feel that they will get something out of this. I mean, most patients participate in trials for altruistic reasons, and that is the major motivation. But nevertheless, you know, at the end of the day, if someone has spent like 2-3 hours contributing their information, which they do not owe you, you know, that is, you know, they would like to feel some sort of appreciation or that they got something out of this participation. So, and here I'm not talking about monetary, but maybe it's an attention control group. Maybe it is a group that gets, you know, your intervention groups get some enhanced care, and then maybe your intervention groups get, you know, basic care, but something, you know, that will not compromise the design of the study, but it would feel fair for everybody that they agree, I will be in the study, I will provide my data, and I will help you, you know, and I will help the scientific community, and maybe it will help others in my situation. But that is, I think that is the part where it requires the biggest, you know, creative thinking. And it comes with challenges, you know, it requires larger sample sizes, and it, you know, you know how it is in research, you change one thing, a lot of things trickle down. But I think for that part for patients is very important, you know, because they felt, okay, you know what if I get the nothing, you know?
I think that it's an essential point that you're making, and I think this was also a learning curve, probably how to also present it to the patient, because you're also learning yourself because you don't know the results of the trial. But I think it's been also a learning for us, including the patients, that both groups actually get something out of it, you know, because when we look at other trials where they compared some surgical intervention with the conservative treatment, they actually both got better, even the conservative group, because if you're in the trial, you have a very high incentive to actually probably do more or better or more, you know, strenuous the conservative treatment as well. And then I think it was important to really include this surgical option, not just for the surgical group. So you have, I mean, in the beginning, it's the randomization, and then you're either the surgery or the conservative arm, but we tell all the patients, and we do the same process for all the patients. We ask the insurance companies to cover the procedure, and they usually do that because they're part of the trial. It's much easier to get that coverage. And the patients randomized to the conservative group, they can get the surgery after they reach the primary endpoint, because after that, it's just it's not randomized anymore, if you want to say so. And that option that they know they can actually both get that treatment if they, after 15 months, decide they want it, even if they're conservative arm. I think that's also important. You know, everyone can get something out of it. Yeah.
Yeah. So I think that's a very important point. Yes. The next point is, I mean, I don't know, maybe we'll go too slow here, but, you know, as a patient advocate, I'm passionate about that, you know, and kind of like really bringing the patient voice. I mean, I cannot talk enough about the consent forms, the lay summary, you know, the attention that, you know, someone needs to pay, that the reading level of all the material needs to be at the 9th grade for Switzerland, for example, because that is the mandatory education. And some terms, breaking them down, you know, and explaining them, it's not easy work, but it is an obligation, I think, of the research community to write all the information in a way that the patients would understand, okay? So I cannot emphasize enough about, the informed consent forms. Sometimes you see consent forms, they are like 15 pages long, 20 pages long, and it's like, okay, this is, how is informed is this consent? That's the question. So lay language, patient-friendly language. I mean, I don't think we can, we can emphasize that enough. And then, the last point is like patient data safety and monitoring committee. I think here as a patient advocate, you may have less to say. Obviously, patients are concerned about the privacy of their data, but how this is managed, I think, the procedures that they are in place to monitor their data is patient advocates, patients, they may not necessarily know how to contribute to that, other than that they need the guarantee from the researcher and the research team that this is going to be taken care of. Evaluation, dissemination, and implementation, these are the steps to come. I mean, understanding the interpretation, what does it really mean? Who needs to get informed about these outcomes? How we will use this information, not only for future studies, but to inform, patients, clinicians, patient advocate groups. I think this is where we are. I don't know, Elizabeth, if you want to add anything to these next steps.
Yeah, I mean, I can only remember, when we were in the process, when we had submitted the protocol, and you kept reminding me, when is the publication coming, when it is coming. And since it really took a long time, although it wasn't rejected, but it just took the journal a long time to finally get it published. But after it was published, we've all actually been contacted by a significant number of patients who read the publication. Some of them also read what you put on clinicaltrials.gov, but the publication itself, again, kind of created even like patients to actually write us if they can participate in the study. So thought it, just kind of all came together that it was Maria as the only co-author, and there are many who kept asking me, but when is it coming? We need it out there. So
Yes, and it creates a wave of self-referrals. But it really shows that patients are interested, and they are, if they really actively looking for an answer to their problem, right? And they find your protocol, and many who are active, and they have they feel confident in raising their voice, and asking, they will contact the investigator for that. And I think this is wonderful. I mean, it really helps what I call democratizing science, making science more democratic, more accessible. It is, after all, it's most of the times it's like, talking in general about SNF funding and, public funding, it is the taxpayers' money that fund this research, right? And it needs to go back to them one way or the other.
very true.
Thank you both very much. And I think with this, we can jump right into questions. I have several questions which I would love to ask you. But first of all, I just want to emphasize how great it is to have you here. And Rising Tide is just so proud to have you amongst our grantees. And indeed, your trial is the only one amongst the 55 active trials that we have in our portfolio at the moment that has patient partner as a co-principal investigator of the study. So you're really our golden stars, and we can only hope that there will be it will inspire many others to follow your lead. And I think a good question to ask at this point will be, Maria, about you and your background. I think all of us here listening cannot help but notice that you have several hats in your equipment, and there is the researcher hat, and there is also the patient hat. And do you think that having only the patient had, do you think that that would be enough to be a co-PI of a clinical trial? And I think this question will be actually to both of you. Yes, so please satisfy my curiosity.
So, I mean, let me say, the fact that I have a background in science and I'm actually a breast cancer researcher myself definitely helps. You know, there is no conflict between being a patient and being this. Now, if I did not have this, this background, or patients who don't have this background, can they also be advocates in a trial? I mean, I think my answer would be yes. Okay. It may take a little bit more work, and it may take a little bit more, you know, the investigators may need to hear a little bit more silently and, you know, pay attention. What is the patient trying to say in between the lines? The lay patients without the scientific background, they don't know the terminologies, they don't know the medical jargon, right? They can only express their experiences, and, you know, some that are more articulate than others, as all of us are, right? But nevertheless, I think they do bring everybody who has been in the position of a patient, they do bring a wealth of experiences from small observations to larger observations about what works, what doesn't work for them. I think it takes a little bit more work, as I said, from the investigator point of view, to carefully listen. You know, what is it that they are trying to say? I think here maybe exactly like the pilot work would help, you know, so that you don't have the input only from one person, but maybe from a small group of people. That would help the investigators move forward. But this is, I think, yeah, this is not. I think the minority of patients would have a scientific background on this particular field. And, you know, maybe if I was a cardiac patient, I'm still like a lay person. If I had, let's say, a heart attack or a stroke, I would be a lay person in that terms, because I don't have expertise in that field. Does it make sense? If it makes sense, what I'm saying.
Yeah. Absolutely. Thank you. Elizabeth, what do you think from your perspective? Would you be able to trust equally if Maria without her scientific background?
Yeah, I think absolutely. I mean, for sure, to me, it was pure luck that she has these two hats. And I think it has, as she correctly pointed out, it just makes it, I think, fast, the communication probably, and the whole process of the protocol development and all that, it makes it more efficient because she had already worked through many of her own before and many others. But on the other side, it's really her patient advocate hat that I think that she had on most of the time, and that, yeah, was most significant to me. I mean, that was the reason why I approached her in the first place, because I had met her as a patient and we hadn't been working together, you know, in research at all. So I actually, you know, to be honest, didn't know too much, you know, how we're all busy and we're just doing our own things. So I didn't really know what, I think it was even after I asked her that I realized that she was actually in breast cancer research herself. You know, I knew she was a professor of nursing science, but I didn't necessarily know that she had kind of a similar scientific background as well. So I definitely would say absolutely, it's not mandatory at all, and it's not a prerequisite to have a scientific background at all. I think I'm just seeing this additional question about in the chat about the compensation in the pilot phase of a trial. I mean, I think there is a lot of additional funding that you can. So do I have to read the question? Sorry for the question, but does everyone see the question, or do you have to?
Let me read the question, okay, just for full clarity. Very often during your pilot work, patient partners do not receive compensation or stipends because the grant hasn't come in yet. How can we ensure that patients are fairly compensated during the pilot phase before the start of the grant?
So I think the essential thing is to work together with an institution like the one we are working with. You know, it's the Department of Clinical Research here, but we are very lucky that they have a lot of experience when it comes to, you know, planning and the setup of a clinical trial. And they should be the ones alerting to possibilities of funding even before your actual trial starts. And even with the, you know, as you said, you're generously funding our trial. The other funding agencies, the National Science Foundation, and also there, even before you apply for this IICT call, like we did, you can apply for funding just to fund the patient involvement. And it's a small, you know, amount, but you can get that covered. And so I think a lot of the funding agencies, if you approach them with that, they will actually fund that because they have realized, like you, or at least I hope others have too, than the ones I'm involved with, how important this is. So I think it's much easier to get this small stipend to involve the patient. So it's never an excuse not to have, you know, compensation for the patients, I would say. Yeah.
Indeed, I can confirm that also Rising Tide has this smaller pre-application grant, which the patient partner and clinician can apply before they start with the letter of intent phase of the application.
And I know from, you know, colleagues who have been, like you said, hopefully it impacts others. And I can say from my, you know, closest surrounding, definitely has. I know that there's also no correlation. You know, you get this support, you get it with a much lower threshold than you would get funding for the whole trial, because they actually don't necessarily even look at the whole trial setup of the trial, because it's really about encouraging the involvement of patients, because it's just so important that we don't do research that is simply irrelevant to the patients. Yeah.
Exactly. Yeah, please, Maria.
Yeah, I mean, I think my understanding is that this is like a newer development, and the world is catching up. And that's the only, I think, what by creating awareness, right, about the importance of these steps, we can only help others see the necessity of that. So, but I think it's a newer development, right? I mean, yeah.
I think it will be also very interesting for our audience to hear specifically how your collaboration started, and maybe your advice how others can facilitate similar collaborations. You briefly mentioned that how you've met, but how did you really decide to embark on this journey together?
I mean, to me, it was, I have to say, it was really Walter Weber who inspired me when it comes to patient advocacy involvement. Because you need to have a mentor, and he was really, or he still is, like my scientific mentor. And very early on, when he created this group of specialists, he also involved patient advocates. So the idea of having patients there at the forefront and having the same weight to their voice, or the same value to their voice, also when it came to scientific publications, so on. This was something that, I don't know, I kind of scientifically grew up with. And then I think specifically to work with Maria was because I knew her from, you know, I knew her as a patient, and I valued her before that. And but maybe Maria, you remember that better. I can't even remember how exactly.
I know, I don't remember exactly. I mean, I do remember exactly what you said. Walter approached to me and some other patients, and, you know, with the idea that a patient advocacy group internationally needs to be created. So, and I mean, at first I really was like, okay, what do I have to do? It's, you don't know what is expected from you, and you know how much time commitment is there. So I think these are the important things for patients, you know, like, oh, you know, what do I have to do, and how much commitment is there, and, you know, well, this is going to be, you know, above my work, additional to my work. So these were some of the things that they were in my mind at the time. And specifically how we started working with Elizabeth, I don't necessarily remember all the details. It was like a foggy period. As I said, patients have a lot of fog around the time of diagnosis and treatment. And I think I'm not the only one. I think that's very common. At some point, I remember reading kind of like an outline of the idea, and that, you know, it was like a draft, and I was, okay, you know, still being in my very foggy head, you know, I was like, okay, you know what, this is very important. And that was the thing that did stick with me. I said, this is so important. And, you know, like, they want to do a pragmatic trial. So that means we are going to be, you know, you really move the needle towards changing practice. So I think that was kind of like, okay, you know, good. This is nice. You know, we're in. I mean, that's my, as I said, well, that's what I remember. You know, it's like very, the details get lost in the.
I remember that it was a very personal and conscious decision of myself that I wanted to have Maria as a co-PI, and that I was actually, so I think it's good that you make it a subject here and a question, and I was actually warned, you know, by others. They were like, oh my God, do you really want to make a patient your co-PI? You know, it's such a, isn't that a big risk? And but somehow it was really the research question, and then in the end, kind of it fits so well together with what we decided as a primary outcome, that she had to be a co-PI, you know, just to give it that value. And of course, you know, the scientific and the protocol, it's in the end, it's a surgical study. So I think that was also really helpful, that it was very clear to Maria that certain things that they were just, you know, said, this can't, you know, she can't, you know, of course, certain things that the surgeon has to decide in the end. But yeah, it was, I remember that it was really something I thought quite a long time about who to involve as a co-PI, and it was no one else who said, you know, it should really be her, you know, or how have you thought about it? It was really something, I remember that it came to my mind, that it just stuck with me. And although it was like a discussion with several people, they not personally like towards her, like, no, they didn't say, oh no, not Maria, but in general, to have a patient.
Yeah.
This was something that I discussed with several people, but I remember that it just felt right. Yeah. And it was the right decision.
Exactly. And what would be your advice? What do you think needs to be done so that this level of participation can become the norm in clinical research?
I think it's in breast cancer, we are fortunate when it comes to that, but Maria can speak then better to that, but it's in my, like how or my perception is that, you know, patients, breast cancer patients, you're generally very well educated about the disease, about, you know, everything. Like it's a community. There's a lot of, you know, not just Facebook groups, but communities. It's well organized and it's being talked about. And then if you go to other cancers, like for example, head and neck cancer, this is completely different story. You know, I think there's other cancer types that are 10, 20, maybe 30 years behind when it comes to that. So I don't know if it's a female thing, or yeah, Maria can speak to that. But that's, I think there I was lucky that there was already this awareness and this voice of the patient that you don't necessarily have when it comes to lung cancer or head and neck cancer, I would say.
Mm-hmm. So there is a certain process of maturation or evolution of the advocacy world within the space. Am I hearing it right?
That's my perception, at least.
Yeah, no, and I agree with you. There has been a lot of research around breast cancer and raising awareness and raising the patient. Look, as a patient advocate, I would say that all patients like to feel heard, no matter what. All patients like to feel heard. But especially for breast cancer, there has been some historical maturity, right, that has increased awareness, has created some structures that enable, you know, the patients to have more voice. And of course, the fact that, you know, we have better outcomes with breast cancer when it comes to morbidity and mortality, that is also an issue, right? It helps because the other issues regarding, like, my morbidity, my mortality for other cancers like head and neck and lung, we are not there yet. So there is far less emphasis on like raising your voice. It's much more the emphasis like, will I survive this? Hopefully, this will be the norm. But I mean, I think as a patient advocate, I would say every patient needs to feel acknowledged. I mean, I think it's a deeply seated need for everyone who's in this, it's a helpless position. You are in a helpless position. You're in a bed and people do things to you, and whatever your decision-making processes are, you were doing before, a lot of that has been stripped from you, right? And now you have to accept this new reality. You have to go through that. And yeah, I mean, this is, I think every patient needs that to say, like, someone hears me and understands me. And for breast cancer, we have a lot of research, we have a lot of history, the structures are there. So hopefully this will be the case for all cancers, not just for breast.
Thank you. And I think this is the perfect moment to wrap up our webinar. I still have lots of questions, and perhaps we need to have a part 2 soon to continue the discussion. Thank you both so much. It was such a pleasure to discuss with you today. And I encourage everyone to reach out to you with any further questions. Yes, thank you, and yeah, have a wonderful day.
Thank you so much. Thank you for giving us the opportunity. We apologize if we speak too much, but I think, this is very close and dear to our hearts, and we have so much to say, that we rarely have the opportunity to, formalize. So we really want to thank you, at least on my end, and I think speaking for Elizabeth too. Bye-bye.
Thank you.